Thank you, everybody, for coming. We're really pleased to have Sarah with us today. Sarah Gehlert is the E. Desmond Lee Professor of Racial and Ethnic Diversity at the George Warren Brown School of Social Work. I know you guys call it the Brown School these days, but I refuse to use that name. And she's also at the Department of Surgery at the Washington University School of Medicine. She is a co-program leader of the Prevention and Control Program at the Siteman Cancer Center, also at the Medical School at WashU, and she serves on the Executive Committee of the University's Institute for Clinical and Translational Science, and is the co-chair of the Center for Community Engaged Research. She's a fellow in the American Association of Social Work and Social Welfare, and the past president of the Society for Social Work. I've known Sarah for many years, and Sarah is a national expert in health disparities, and especially with the focus on women's health. And before she was at Washington University, she was also a professor at the University of Chicago, where she headed up a number of significant grants and a center that focuses on women's health and health disparities. So we're really pleased that you're able to come and speak with us today, Sarah.
Is my mic on? Can you hear me? Let me see. Yep, it's on.
Tell you what, we can move also this a little bit.
Yeah, I was the kid who was never chosen for the school plays because you couldn't hear me. So, do my best with the mic. I knew your dean when he was a student. That's how old I am. And you get all those titles when you've been around a long, long time. They just sort of accumulate. So it's wonderful to be here today. This is a beautiful campus. It's my first visit, and I love this school. I love that window, actually. I'm going to talk today about social factors in breast cancer disparities, actually. And this is work that I started at the University of Chicago and is ongoing there. And I'm going to talk about how we've translated it in St. Louis. And by the way, it really is the George Warren Brown School of Social Work. We say that, even though we added public health. There's a rumor that we called it then the Brown School, but it's social work. Or I wouldn't be there, I think. So talk a little background about health disparities. People started talking about health disparities in the 1970s, but it really wasn't until 1990 when the US Census for the first time collected data on mortality by ethnic group for all 50 states, that it was impossible not to see how huge the differences were across racial and ethnic groups. And everybody in Washington, D.C. scrambled. President Clinton launched the Racial and Ethnic Health Disparities Initiative. Each of the centers and the institutes at the National Institutes of Health had to have a health disparities section. And by 2000, health disparities was named one of the two overarching goals of Healthy People 2010. We haven't made as much progress as we'd like, and I'm going to talk about a reason I think that that's the case. So it was just in last year that for the first time we had data on health screening behaviors by ethnic subgroups. So for instance, we now, and I'm going to show you a slide, we can compare who gets mammograms, and it will probably surprise you, and who gets PSA screening, all sorts of things like that. So this slide is a little bit old, but just to give you a rough idea, this is taking all kinds of cancer and putting them on the same graph and looking at changes through time by racial and ethnic group. So we've got on this end, 1992, we started, as I told you, collecting data on ethnic groups in 1990. And what you see when we put all these cancers together is that African Americans have the highest incidence rates, followed pretty darn closely by white Americans, and it's getting closer. And then the lowest incidence is American Indian, Alaska Native, and in between Asian or Pacific Islander, and Hispanic. Now, if you looked at different kinds of cancer, the picture would not look like this, but just to give you some idea. And when we then look instead at who gets cancer but who dies from it, we see the pattern, the stacking is about the same, although mortality rates are much worse than incident rates for African Americans, and the difference between white and black Americans has grown. And Asian American, Alaska Native, Asian or Pacific Islander, and Hispanics are much more closely clustered. So if we move then to breast cancer, which is what I want to use as an example in terms of the determinants of a disparity, this goes back to 1975. Richard Nixon declared, you may not remember Richard Nixon, some of us do, not necessarily fondly, but we remember him. And in his State of the Union address in 1971, he declared war on cancer, and it's another war that we didn't really win. So you can see that in terms of mortality from breast cancer, that African Americans and white women in the United States, this is for women, started out pretty close in terms of mortality. And it was really in the 1980s that there started to be a divergence, and it's continued to increase. These are the three ethnic groups that I talked about. Remember, I said we just started gathering data there in 1990, so that's why they don't go back to 1975. So what's going on here? I'm going to focus on black and white disparities, African American and white disparities, and this is what is disturbing. So if you look over here at incidence rates, and you can see this is white and this is black, you can see that from when we started collecting data, white women have always been more likely to get breast cancer. Just the way it is, and the gap has not been very different. But when you look at mortality, you see a different pattern. So you've got white and black women, as we saw in the previous slide, not being very different in the 1970s, and the gap growing. So that now, black women in the United States are 37% more likely to die from breast cancer than white women, even though they're less likely to get it. So why? And just one other slide that came out recently. This is black and white breast cancer disparity, 3-year average for 4 cities in the United States, well, for the United States as a whole, and then 3 cities. And what you see is that it differs by where a woman lives. So that it tells us, for one thing, it's probably not biological, or certainly not largely biological. You've got very low rates in New York City. I mean, not low enough, but low comparatively, lower than the national average. Very high. Chicago has about the highest in the United States, followed by St. Louis. I couldn't find Denver. I don't think that Denver's been put on a graph like this. So why might this be the case? Certainly look at access to services, availability of services. That would be sort of our working hypothesis at this point. So I just want to talk about NCI, the National Cancer Institute, really was the first part of National Institutes of Health to address health disparities. They came out pretty early and strongly because cancer disparities are great. And their response was to come up with these big center grants, throw money at it. And the first one was in 1999. It was the Transdisciplinary Tobacco Use Research Centers, followed in 2003 with the Centers for Population Health and Health Disparities. I was a principal investigator in one of the first of these, the first round. And then in 2005, Transdisciplinary Research on Energetics and Cancer. And that just means obesity and cancer. And we now have one of these, one of the 4 centers in St. Louis. So why did they do it this way? Why did they go transdisciplinary? Well, this is what NIH said, NCI actually. The determinants of disparities are multi-level complex, and their interrelationships are poorly understood. I think any social worker could have told them this, that we're talking about systems, and that you need synergy across the biological, clinical, social, and behavioral sciences to really understand this incredibly complex phenomenon. We know part of it has to do with ancestry, but not very much. We know part of it has to do with access to care. It's complex. We also need to prepare the new generation of transdisciplinary investigators. And actually, at the SWIR meetings this coming January, we're going to have a workshop on transdisciplinarity in social work, working with other disciplines. We were talking last night at dinner that often when you're on one of these transdisciplinary teams, as a social worker, you end up being the therapist for the team, but that's okay. You have more skills. You just have to use them wisely. Okay. So the Centers for Population Health and Health Disparities, of which I was one of the PIs in the first round, was established in 2003. It was directed at cancer disparities, and there were 8 centers in the United States, each with at least 3 interdependent research projects addressing biological, behavioral, and social aspects of health. And interdependent, meaning that it wasn't like the old kind of research center we used to have where one project was looking at the psychological impact of something, one was looking at the biology, and another was looking at social factors, and they all went off and did their own thing and then came together at the end and tried to make some sense out of it, and it never quite worked. So this was a challenge to be interdependent, that each project in the center had to have all of these components, all of these disciplines. So, and we put out something in 2007 called Cells to Society, Overcoming Health Disparities. So the idea was, and again, this is very social work friendly, that you would put together biomarker and animal model studies, preclinical and clinical studies, and impact on patient and community, and you would do it in a neighborhood and community context. Everything was infused with community engagement, and we talked about this being an incubator. And so these biomarker studies were looking at genetics, biological basis of disparities, biomarkers for risk assessment and screening, preclinical etiology screening and treatment, and dissemination of research, quality of life, access to care, and policy. So even though each center had to contain all this, and each project should be infused with all 3. So what do we know briefly about the causes of disparities? Well, what potentially causes it? Certainly macro level factors, regulations, policies, societal views about cancer. Genetic factors, there's some inherited mutations, there are some sporadic mutations. We now know that what you do, what you're exposed to in the social environment and the chemical environment can change the context of your genes, basically, to produce disease. And something called telomere length. So there are individual level factors, diet, physical activity, health behaviors. This is what's been focused on over almost anything else. Sometimes even in an old Piven and Cloward blame the victim way. If people would just get that mammogram, if they would just, go to the gym, they wouldn't have cancer. So meso-level factors, we now know that early family relationships have something to do with who gets what kind of breast cancer. And lastly, demographic factors, age, gender, ancestry, all important. You can't just focus on one and then have others focus on other things and again come together later and try to make sense of it. You've got to take the bigger picture the whole time. So this is something we published early, just looking at the levels of determinants of cancer. So they go from social conditions and policies, which is culture, norms, racism, sexism, discrimination, public policies, poverty, we call this fundamental causes, and institutional factors, the healthcare system, families, churches, community-based organizations, legal system, I won't read them all, neighborhood level factors, collective efficacy, social capital, access to resources, social cohesion, neighborhood stability, social relationships, networks, social support, social engagement, individual level factors we talked about, and then biological genetic pathways. And what we realized that these things, they interact completely, so that these factors in some senses affect policy and how people feel about societal views of cancer. I can give you an example. We found that women who live, another center did a study on the south side of Chicago, and they were looking at, in a largely African American impoverished area, not all of it, it's also the area where Minister Farrakhan lives and where the Obamas live, that it really wasn't the case that there wasn't access to mammography. Women could get to mammograms through community health clinics, but what was the case was the quality of the mammograms there were horrible. That there was one mammographer, often part-time, who would come in, take a film. It wasn't digital, so if they couldn't, if they weren't sure about something, they couldn't just run down and get another mammographer to look at it. And they couldn't send it by computer to a hospital to have somebody look at it. They had to make a decision themselves. So that was the case. And we also know that African American women have a propensity toward an early, more aggressive form of breast cancer. So to me, that's a perfect storm. If you've got to try to find the early form that grows fast, and you're in an environment with poor mammography, you're at a very great disadvantage compared to someone in other circumstances. So we began to really pay attention to how these things interact, and also we realized that if you change things upstream, if you change neighborhoods, you'll end up changing some of these other factors. And it's very, it's an efficient way to do it that doesn't always happen. So, what do we know about health disparities? Briefly again, we know that about 40% is probably due to behavior patterns. This is, well, I'll tell you about the study, but about 30% due to genetic predisposition, maybe 15% social circumstances, maybe 10% shortfalls in medical care. I'll explain these in a minute. And maybe environmental exposure, so exposure to toxins, the stuff they spray on mattresses to keep flame retardant is implicated in breast cancer. This was based on a review of 500 articles. It was a meta-analysis where they tried to come up with just really what had been linked. So you know most of these, so behavior patterns, pretty clear. Genetics, again, not just whether you inherited the gene, but whether you have this genetic propensity toward an earlier form or not based on your ancestry. Social circumstances, discrimination, availability of services, shortfalls in medical care, physician bias and other provider bias. We're finding it's not just physician bias, but it's kind of like street level bureaucracy. Did you read that in a policy course? Yeah, the people who are at the door of a clinic have a lot to do with how people are treated. Toxins, pollution, secondhand smoke. So we'll just sort of layer these over what we saw earlier. And that's kind of our conceptual model of what needs to be part of the project. So why we made so little progress in addressing disparities? I think, and many others do, we focused on these behavioral patterns and genetics to the exclusion of other determinants such as social circumstances, which we didn't look at until very recently, and shortfalls in medical care, so bias of providers. And we've neglected the interactions between the two, like the example I gave you, and also how genetic propensity might affect your response to what's prescribed to you to increase your survival or not get cancer. So we now know, for instance, that there are subgroups of women and men who get different pleasure from exercise. They're literally, now you can find some groups, like me, who get endorphins. When I go to the gym, I get like high. Other people hate it. I mean, they just get sweaty and uncomfortable. So if you are trying to prescribe something for somebody, prescribing something that's going to make them miserable is not the best way to do it. And then we end up saying, well, they just didn't want to exercise. And another thing is we now know there are 3 subgroups, genetic subgroups of level of addiction to tobacco. So if somebody is in the hardest core addicted, you might not want to use the same intervention. You pick the intervention based on a little bit on biology. Okay, so I talked about the fact that we talk about health behaviors. Well, it turns out now, this is from January 2012 in Morbidity and Mortality Weekly, that Black women have higher rates of mammography screening than white women. But every time I talk to the medical students, a new group comes, I say, who has the lowest rates of screening mammography? They go, Black women. I say, no. You've got to keep up. It's not good. So now the lowest rates are among Asian American women in the US, and especially Filipinas have the lowest rates. So we've really got to know in designing interventions or setting up clinic services some of these things. How much of it has to do with just you're born with the gene and you're going to get breast cancer no matter what? Very little. And a lot of people don't know this too. A low percentage of cancers are thought to be caused by hereditary mutations. 5 to 10% for breast cancer, 10 to 15% for lung and prostate cancer, and 20% for colorectal. A higher percentage are due to sporadic or acquired mutations across the life cycle. So what you're exposed to in terms of the chemical environment and the social environment have a lot to do with whether you develop breast cancer and what kind that you develop. So social circumstances are the least studied determinants and potentially the most significant. So if we just looked the way you look traditionally at it, just looked at race and gender, this is a picture you'd see. This is 1920, it's estimated, to present, and it looks as if white females have the highest life expectancy at birth, followed by white males, and then Black females and Black males. Okay, so if you just look at gender and race, this is what you see. Throw in even one social variable and the whole picture changes. So here, Mira and her colleagues divided the group again by highest level of education and lowest level of education. And then they looked at change in life expectancy at age 25 between 1990 and 2000. So you want this to go up. You want a nice blue line, right? You want things to go in this direction. Well, for people with high education, it kind of operates the way we saw in the last slide. But when you look at people with very low levels of education, the group with the lowest gains are actually white women, followed by African American women. Nobody's completely sure why. But education is a very important factor. Mira and her colleagues think it has to do with smoking, because white women with very low levels of education have the highest rates of smoking, and Black women's rates are lower. Not sure, but my point is, throw in a social variable, it changes. So this is something that just came out in August, J. Orshansky in Health Affairs, and this just speaks again to how important education is. So if you look, this is white women. I'll show you another one in a minute, with less than a high school education. Okay, then high school, college, and really professional graduate. And then we look through time. So you can see that the higher your education, the longer you can expect to live. We're not surprised, right? Except there's not that much gain. Don't quit graduate school, but you don't gain that much in life expectancy from going beyond a bachelor's degree. And you see also that we like the fact that it's kind of gone up from 1990 to 2008, right? Education will get you more through time, except if you're less than a high school graduate. And if you're less than a high school graduate, you have very low life expectancy and you're losing ground through time. So the social situation of people in the United States with less than a high school education is worsening. Now, this is another thing from the same article, and it looks at race and gender, and it basically showing you what more years of education get you by gender and race. So it's kind of like the slide before. If you are a white woman, going to school is really going to increase your life expectancy. You're getting something for that education. And this is white men, about the same thing. But if you are a Black or Hispanic woman, education isn't getting you the same gain in health in the US, which is an enormous problem. And my colleague, Tom Leveist, who runs the Health Disparities Center at Johns Hopkins, really says now that we should not even pretend we're able to control for education and compare two races, because education doesn't mean the same thing. So you really can't say you're holding it constant. So this is very worrisome. So I'm going to talk a little bit about what our center did in our approach. We were, it's still ongoing. I'm not there. I moved to St. Louis. I still work with my colleagues, but we were working in the Cancer Risk Clinic, the Institute for Mind and Biology. It was neutral space on campus, so it wasn't like the med school had more weight than the School of Social Work. And we were in Nigeria. I'm not going to talk about that. So I was principal investigator. Martha McClintock, who was a biological psychologist, led one project. Suzanne Konzen, who is a breast oncologist, who is a molecular biologist. Fumio Lopade, who runs the high-risk genetics clinic at University of Chicago and is a geneticist. And Tomasz Kraus, who was from chair of the Department of Pathology. We came together because there was a request for applications, and long story short, decided to do this. And they asked me to be principal investigator because they knew it was going to take a lot to pull it together. It's like, who are you going to call? A social worker. And it was incredibly difficult. Everything I learned about group theory and process, I used. Every trick in the book. So what brought us all together was the question, how do factors in women's social environments contribute to the African American and white disparity in breast cancer mortality in the US? The clinicians knew because they knew that no matter how good the drugs they had were, Black women were still surviving at lower rates. And everybody came together on this question. And so how much of breast cancer, I showed you before, but I just want to give you some idea. Only about 5 to 10% is known to be due to inherited mutations. We know that there are some families that have high rates, but we can't quite put our finger on why. Science isn't there yet. But 70 to 80% of breast cancer is due to something that happens to you from birth to this moment, something that you were exposed to that sort of uncovers this propensity toward breast cancer. And let's see. So our model, we had to come together and agree on a model, was that race doesn't equal biology. Race, it doesn't really equal social circumstances, but in the United States, your race certainly to a certain extent determines the social circumstances in which you live. And that leads to certain psychological states, which lead to neuroendocrine and gene expression changes, which lead to the survival of cells that mutate. So sad as it is, we're all having little mutations as we sit here, but in a healthy human being, they're repaired. You repair them. If you're not healthy, you don't repair the mutations. And then in the case of breast cancer, they kind of form into tumors. So So it's a way of going from social process to genes, which is flipped from the way we used to look at it. And it is an important role for social work up in this area. And so this is the model we put together. These were women, except for Dr. Krauss. And we decided that we would try to look at the whole range of things that might be affecting these women and causing an early form of breast cancer, which is what we were looking at. So 2 projects looked at women on the south side of Chicago, Fumio Lopade and mine, and these were women at Stroger Hospital, Mount Sinai and University of Chicago, and Stroger's a public hospital, Cook County Hospital it used to be called, and 2 did animal models. Now, why animal models, and why would a social worker be PI of something that used animal models? First of all, they didn't do anything horrible to the animals. They just changed their social arrangements. Okay, no catheters, no nothing like that. And you can actually take a lifespan perspective then. You can follow the animal from in utero till it dies, and you can manipulate the social conditions like crowd it, isolate it, and see how that will affect tumor growth. And these are, we used 2 genetically altered mouse and Sprague-Dawley rat. And so altogether we were able to look from the community neighborhood level, that's with the humans, not with the animals, at crime, collective efficacy, social ecology of neighborhoods, to housing, environmental exposure, social circumstances, especially isolation and social support, psychological states, depression, anxiety, felt loneliness, behavior patterns, hormones, and genes. So we had to spend a lot of time together, not always in total agreement. So this is Martha McClintock's animal study. And what she did, these are female rats, and this is the way they like to be. They pile on top of one another. They share the little pup rearing. This animal, oops, sorry. That animal is in the preferred position. I mean, that's where they all want to be. They rotate. This is like the next best position. And so they're happy. If you leave them to their own devices, this is what they will do. And what Martha did was just take the rats out and put them in a cage by themselves. All she did was socially isolate them, and I won't give you the background for why she did that. Same food, same room, same caretaker, same absolutely everything. And what she found was that the animals that were isolated became vigilant. It affected their behavior. So here you're looking at a cage from the top. All of these are caged from the top. You're looking down. It's an open cage. And this is a food dish that was overturned. It's a novel stimulus, okay? And the blue is this software that allows you to follow one rat's footprints for 24 hours. So what you can see is the animals that were left in that happy group explored their environments. They looked at this food dish like it's healthy to do. You need to just sort of get to know your environment. But the animals that were isolated, especially those that were isolated when they were in puberty, were altered. They would stand in a corner of the cage and just look like this all the time for threats. And when you put them back in the social group, and it was a kid in an inner city high school who gave us this idea, by the way. NPR had me talk to inner city high school students, and a 14-year-old raised his hand and said, "But what happens when you put it back in the group?" And I said, "Good question," and went off and called Martha McClintock and said, "This kid had the best idea ever." And we told him, because he was really, really smart. They don't know how to act. So you put them back in their social group and they run into the other rats and they look at the other rats for clues, and they just absolutely don't know how to act. So we try to figure out, how is the social environment getting under the skin to affect these animals? And we found, first of all, that the isolated animals developed these big tumors, big old tumors. And the animals that were left to their own devices looked just fine. And these female rats that were isolated, just taken out of the cage, also quit grooming themselves. And so how did just changing the social grouping result in this big change in biology, so that these animals had big tumors that were malignant in about the same ratio as we see in women? And so Suzanne Konzen started looking at the stress hormone. Oh, she found first that the tumor burden of the isolated animals was about 84 times greater than of the group housed. So the animals that were isolated, stressed in that way, were just really, really affected and had more tumors and died early. So when she tried to understand how, she looked at stress hormone. And this is the group housed animals, and this is the isolated animals. And all we did was measure the stress hormone levels before we did anything. Then we just moved the cage. We just moved the cage about a foot away. And then we looked at the stress hormone levels 30, 90, and 150 minutes later. And this is what you see in Psychology 101 textbooks. So your stress hormone levels go up and they go down. Just if I scared you now, that's what would happen. But the animals that were isolated, levels went way up and they didn't return. And Martha's postdoc was able to show that how high it went explained whether or not they got a tumor, and how slow or quickly it went down determined how long they lived. So we knew we were onto something. So we were working, this is Chicago, this is 15 neighborhoods on the south side, this is Lake Michigan, it's the University of Chicago, Hyde Park. And so we decided to work with women in these areas. It's largely African American, some very affluent, Bronzeville, some not affluent at all, Englewood, where Jennifer Hudson's family was murdered, some wonderful neighborhoods, some neighborhoods that are not so wonderful. And we also did community-based participatory research with people from these areas, but I'm not going to talk about that today. So we focused deep in these areas. We followed 300 women who were diagnosed with breast cancer, and through time. We followed them for a year and a half. So at first, we were just going to go into the surgery suite after they had their tumors taken out, their breast cancer, and Dr. Olopati was going to look at the tumors to see if it was the early form, not the early form, and then we followed to see how long women lived. And my group of social workers was going into the women's homes to interview them there 4 to 6 weeks after their surgery. And we did it in their homes because we wanted them to feel more comfortable, plus people don't feel you don't get as much response bias when people are in their own homes. You drag them onto a campus and they feel they often have to please you, which isn't what we want. So we were going to just do these in-home interviews, and this is just a few of the things we looked at: psychosocial functioning, perceived discrimination, perceived stress, social network analysis. And we took salivary cortisol. We just had women chew a little sponge and spit into a tube to see what their body was saying their stress levels were. And then we were going to compare that to geocoded data from the neighborhoods. The city of Chicago has violent crime data that we could measure for each woman. We sort of drew a quarter-mile buffer zone around each woman's home and counted the crimes. And that way we could compare exposure to threats across women. We also did that for collective efficacy, dilapidation of housing. City of Chicago's got very good data. But then we discovered that this was just too gross. It wasn't capturing things. So we started measuring neighborhood. I had to learn what built environment was, and I had to learn it fast. So we then measured the 4-block area around each woman's home. We went and mapped it. We looked for things that were opportunities for social interaction, like vacant lots. It could be used for softball, like neighborhood watch, sharing childcare. But we also looked for things that impeded social interaction, like vacant lots that had a lot of used condoms and syringes, and buildings that were boarded up but not well, so they'd become big drug houses. And we measured this for all women. So you see we're getting a lot of levels here. So I had this on my desk. This was what I showed you before, and this is one of the students going in to measure a vacant lot, because we wanted to see whether the vacant lot was used for interaction or whether it was so frightening that it kept women as prisoners in their own homes. And I had this here, which was a satellite map of one woman's home, so we could go in and know what we were mapping. And it occurred to me, after looking at it, that the same way we manipulated the social environment to produce the stress and the tumors in the animals was happening in neighborhoods. The nature of neighborhoods, due to local policy, state policy, really changed the character of neighborhoods to produce stress and other things that seem to be associated with these kind of tumors in women. So, so this is one thing we measured. We had women chew the salivettes to get their stress levels, and you do it through the day, like when you wake up in the morning, 30 minutes later, noon, and then bedtime, and then the next day. And so we had these data for the women. And this is kind of what probably is happening to you, except when you're taking finals or writing papers. You know, your levels go down at night because you don't need to be activated, right? And then you wake up in the day and they go up just to get you ready for the day, and then they go down through the day. And now we know that women in the first 2 weeks after they've given birth have really high levels because you've got to be alert to take care of the baby, right? So we cluster analyzed these scores for the women. And I was just sort of doing it. I was getting to know my data, as we say. And what we found was 2 clusters of women. We found one cluster of women that kind of acted like the isolated animals. Their levels went up and down, they were high. But we found this other group of women that were just flat. So when they woke up in the morning, they couldn't muster stress hormone levels to get them ready for the day. And it was about 67% of women. So we're trying to figure out what would happen. And when we looked at who the women were, we found that these are the women who'd lived in circumstances with high crime, poor quality housing, in which threats were real, and they couldn't really go indoors to lock a bunch of doors or go to a high rise with somebody at the door to protect them. So they had experienced this a lot of their lives. And these are the women that told us they couldn't sleep at night. They always had to keep one eye open or one ear open for threats, like somebody breaking in. So, and now David Williams at Harvard, the sociologist, you may know David Williams' work, is doing some work in this area too. And what he's finding is that women who are like this, who have sleep disturbance because they have to, be aware, have what we call perseverative cognitions. All night they're going, is the door locked? Did I hear something? They're sort of going through, do I hear anything? Are the doors all locked? Am I safe? Are my children safe? And this seems to really be implicated in many, many downstream biological changes. So we found that and also these were the women who, when we'd asked them what are the best and worst things that are happening to you now, put breast cancer as third or fourth worst thing happening. It was get food, find housing. These are the women who said breast cancer, it's horrible. And these are the women also we couldn't find for follow-up. Most of the homeless women were in this group. But when we looked again, it was an independent covariate of having triple-negative breast cancer. Now, triple-negative breast cancer you've maybe heard about. I'll tell you a little bit. Why do we care? Triple-negative breast cancer is most common among African American women, followed by Hispanic women. It's overrepresented among African American women. It was once on a gene, my friends think, that was adaptive, but no longer so. African American women are 3 times more likely to be diagnosed with triple-negative breast cancer than white women. And mortality from triple-negative is twice as high as non-triple-negative. And also, there's no treatment for it now. So tamoxifen works if you have ER-positive breast cancer, and there's something called Herceptin now if you have estrogen receptor positive and progesterone receptor positive, and HER2 is the third hormone, negative. But if you've got all 3 negative, there is currently no drug. And that gets you to that top level because drug companies do not want to spend money trying to develop a drug that they think will only be bought by a smaller percentage of the population and one that doesn't have as much money to pay for the drug. So this is why we're concerned. So we were able to, with regression, looking at the robberies in that quarter-mile buffer zone and homicides and whether or not women were depressed, pick out which of those two groups they were in, the flat or 50% of the time. So these things really did help predict. And together, as a group, we were able to go from this degraded infrastructure crime and unsafe housing level to these psychological responses that we saw: isolation, depression, vigilance. We found a biological pathway through sexual assault. In the other direction, when you've got collective efficacy, it's a negative. You don't make this link, which is nice. So 2-factor we found on this. We found some women who were depressed and lonely, and another group of women that they weren't depressed and lonely, but they had no idea where they fit into the universe. We call it anomy. They didn't know why they were on Earth. They didn't know how they fit in. They were isolated. So they were disenfranchised by virtue of their group, but also individually disenfranchised, which is incredibly devastating. So then, through my colleagues' work, we were able to find a biological pathway to these salivary cord groups that I showed you, an inflammatory response down into the gene to glucocorticoid receptors and alterations in metabolic and inflammatory genes. So it took kind of a group to be able to do this. Okay, so we went from the population level, social isolation, threatening environment through my work, to the individual level, vigilance, dysregulated stress hormone response through my work and the animal models, and then to the tumor level, changes in gene expression, more aggressive tumors in Fumi's project. So we had to be transdisciplinary. I'll just show you a couple more. So how are we approaching this? Well, we're trying to act upstream to make changes downstream. So they're continuing to look at these pathways. I'm trying to address this decrease in social or increase in social isolation and feelings of not fitting by interventions to increase support and build networks, social networks where they don't exist. And we hope we have a neighborhood level intervention to improve clinical and biological outcomes. So in looking at this, it was really funny. I looked at a book by Mindy Fullilove, who's a psychiatrist and public health person at Columbia University. I can't remember, Root Shock, is that her? I think that's the name of her book. She talks about how neighborhoods, inner city neighborhoods have changed in the US. And she just kind of had a throw-off line that she didn't do anything with. And she said, we almost need to go back to settlement houses. You've got women who are isolated in neighborhoods. They don't have any place to go. They can't connect. They're prisoners in their own homes. And I thought, hey, that's not a bad idea. We're not talking about a settlement house where you teach somebody English or skills, but a safe place to go, get social affiliation, and maybe help to learn some skills to deal with some of these systems that we all have trouble dealing with. Okay, so in St. Louis, we just went 294 miles. So we have the St. Louis Komen project. It's a CBPR project with 4 community and 1 academic partner, and a purpose of reducing the African American white disparity in breast cancer mortality in North St. Louis. So my partners are, well, that's a funder, People's Health Center, which is the largest federally qualified health clinic in St. Louis. And this is the CEO, Dwayne Butler, and this is People's, one of its sites, and that's Cheryl Jackson, who runs the breast services. We are Committed Caring Faith Communities, which is a group of African American clergy that were interested in health, and mostly substance abuse, HIV/AIDS. We are Christian Hospital, which is the other hospital that treats women in the breast and cervical cancer program in North St. Louis, and St. Louis Effort for AIDS, which may seem, this is Tabasha Halloran and Cheryl Oliver. St. Louis Effort for AIDS because they have a women's wellness program with a van that goes into the most impoverished neighborhoods, and they have rapport. So they were thrilled to be our partners. And these are the academic funders. So this is just to give you a rough idea. This is St. Louis. This is the Mississippi River. And this is North St. Louis City, which has markedly worse health outcomes than the south side of the city. This is just cancer mortality, and the dark green is the highest levels. And this is downtown, which is kind of nicer in terms of having services. And if you look at the deaths per 100,000 in two zip codes that are right next to each other, it just startled me. So in this one, 178.8 per 100,000. In this one, almost twice as much. And you can just literally cross the street and be in the other zip code. So we decided to work in this area of North St. Louis. We decided to put our office in one of the zip codes. Well, it's the zip code with the lowest life expectancy at birth. So let's see what we got here. So we put this center at 3335 North Union, and it's open 40 hours a week. It's a safe place. It's on a bus route. It's near a laundromat. It's accessible. We have groups for neighborhood women. We're starting the first support group for Black lesbian women with breast cancer in St. Louis. We've got support groups for women with serious mental illness with breast cancer, who have drug and alcohol problems, women who didn't feel comfortable being part of any other group. So we do that from the office. We have a tutoring program for middle school students because that's what the neighborhood told us they needed, by WashU, the Washington University Association of Black Students. We do community presentations whenever we're asked. We were at a women's shelter last week, and we do the programs too in inner city high schools, and African American women physicians who specialize in breast cancer do the programs. And we teach a course called Research 101 for community residents, which is just kind of, I call it research doesn't make a lick of sense. It's like, why do we do it? How might it help you? And I didn't know who would come, the first 16-hour course. And people came and had very good questions. We've also done 12 community focus groups and 82 interviews with women who live in the 8 zip codes with breast cancer who were treated during a certain period in the breast and cervical cancer program. But in this class, and in the focus groups, what we hear is that people don't dislike or disrespect research. They just think it's in a different planet from them. And so I run the community engagement unit at our CTSA, and I hear the physicians saying we can't get ethnic minorities in our clinical studies. And then I go to the neighborhood, to the office, and they say we try to get on and we can't get on. And it's just a real failure in communication. But the questions that people asked were very sophisticated, such as, how do they come up with you need a mammogram at 40 or 50? Explain that to me. So there were really, really good questions. And I think that one more slide, just summing up. To eliminate health disparities, we need these multi-level interventions. I don't think you can work at one level and expect it to be effective, to make a change. Focusing on one level will make a dent. It won't make a dent. It really won't. It might help that one person, but you're still going to have group differences. You need transdisciplinary teams of investigators to cover those levels, and you really need to partner with community stakeholders. So that's it. Do you have questions? Does this seem, yeah. Oh, thank you. Thank you. Yeah.
Is Komen funding projects similar to this across the United States? And the second part to that question, is this going to be something that's studied longitudinally to see if there's an impact?
Yeah. So, okay. Komen's funding 7 of them in the U.S. And Komen, it's been a little problematic with the whole Planned Parenthood thing. This is something they do well, and gotta hand it to them. Unlike NIH will say, here, take this money and publish. But Komen actually does say, it better make a difference and you better show us, and we'll keep funding you if you do. So the ones that they've funded have been funded for years. We have to reapply every 2 years, but They want it to be sustainable, and they certainly take that office being there as important. We're not going to move, you know, that would be too many people come in, do something, leave. So they have made that commitment, and it would be better if they funded more. Yeah.
How did you find the women who tested the triple negative? Or I'm assuming that that's what you used for the St. Louis.
For the St. Louis, right. So we did several things. We went to the state tumor registry, and we could get de-identified data, so we knew where women were diagnosed, what kind of tumors they had, and how much treatment they'd undergone. But it was de-identified, so we worked at the zip code level. And then when we wanted to do the interviews with women, because I really wanted to see what their treatment was like in their own words, so we went to their homes again, because I don't want to drag people out. The tumor registry sent women letters saying there is this study, and if you want to be in it, call this number. But what happened was that we weren't getting enough women who didn't go all the way through treatment. We were interested in how we contributed to women not finishing treatment. Very concerned about that. So we started, that's when the St. Louis Effort for AIDS van worked, because they had credibility and they passed out the flyers. Because if you pass them out in the clinics, that's people who are already engaged in some kind of treatment. They're already part of the system. We wanted people who are really driving these disparities, who aren't included in research studies and who aren't talked to. And I honestly think that because when we do health disparities research, sometimes we go to the group that's most like us, and we work with them and we make their plights better, but that just makes them further away from this group that really, whose lives are most uncomfortable, most problematic. So that's what we're trying to do. And we've had a really good response from women. We just said, you know, call us, but we thought we could do 100. We took all the women we knew from the cancer registry who was diagnosed with cancer between 2000 and 2008 when they lived in those 8 zip codes. And we knew there were 932 women, and now 432 are still alive. So we wanted to talk to 100 of them. And I'm using 2 social work doctoral students, African American, who are very, very good qualitative narrative interviewers. And we've finished, when I left, 92 out of 100 in 2-hour interviews and looking at the data. And one thing we're finding, sorry, I didn't mean to throw this in, if you have to kick me out, do, but we're finding that when women are told when they're offered different treatments, either they don't get or it's not said well, or both. They think that radiation is an option, just an option, like reconstruction after you've had your breast removed. They're not connecting it with survival. So a lot of women were not opting for radiation. And so I don't know if the physicians aren't tying it to, if you have this, it will increase your odds of survival. Or if women's health literacy is low and they're not or they're just too frightened at that point, because I would be. But that's one thing we're finding. We're also finding that the women who drop out of treatment, 50% of them drop out before they even start treatment. And we think we have a handle on that too, because they're diagnosed at the federally qualified health clinics, People's especially, and if there's a suspicious mammogram, they let the woman go home and call her back. Okay, so this is a woman who doesn't think anything's wrong with her, right? She has no pain, probably. She might not come back. The kids need something. She doesn't have transportation. And then if she comes back and sees that primary care doc, he sends her home again and then gives the navigator her number. And the navigators were so frustrated because they couldn't get women. It would be somebody else's cell phone by the time they called, or it wasn't. And so the navigators, when I did a focus group with them, were extremely frustrated. And they also didn't feel, their peer navigators, they didn't feel that they had the tools when women expressed a great deal of fear to to help them through that fear. So we're going to do some training of the navigators so that they'll feel more like they're better equipped to deal with that. So those are some of the things we're doing. But at the same time, just trying to make this safe place and see if that makes a difference. And it's, we're trying to get other safe places on the north side, but funding constraints. Yeah.
I was in a conversation recently with someone, and we were talking about, just the medical student. There's another health disparities kind of conversations, but the fact that medical providers, doctors, perhaps nurses don't look like you, and how that factors into that lack of communication, that you spoke about earlier. And I'm just wondering if you kind of saw any of that.
Well, the navigators are of the same race ethnicity, but not always the same socioeconomic status. So sometimes, you might still not be able to connect. But if when women come to the oncology clinic at Christian Hospital or at Barnes-Jewish, which is the Washington Universities, we know that, I'll give you a quiz. When was Flexner? Did you have to learn that in history? Okay, Flexner, 1915, was it? When Flexner, yeah, they're nodding. 2.3% of physicians in the United States then were African American. You know what percent of physicians today are African American? 2.5. So what are the odds? And they're less likely to go into specialties. So when you get to that point, it's much less likely that the person will look like you. Plus, women have to come from neighborhoods where they've spent their whole lives to these hospitals that are, they overwhelm me. I don't like being a patient there. It's kind of like, where am I supposed to be and what am I supposed to do? So it's very uncomfortable. Yeah.
So I have a follow-up question. I'm actually from St. Louis and I grew up in these neighborhoods. So I'm curious about that piece around, because I know that there has been a trend, especially in St. Louis, in the North City, hospitals and clinics are disappearing. And so how are you guys sort of reacting to that, given sort of this huge issue around?
We're reacting badly. When I left, so there was this wonderful hospital in St. Louis called Homer G. Phillips that trained some of the best physicians and nurses in the country. And then it disappeared. And then there was City Hospital. And then there was St. Louis Regional Medical Center on Del Mar when I left for Chicago. And when I came back, I wasn't there. There were no public hospitals. So that's definitely a factor. The federally qualified health clinics are good, and they now have electronic medical records that are shared with the hospitals, because a woman can't get surgery in the FQHC, right? But it's an enormous factor. And what they've tried to do is try to put more money into care, but it's not the same thing. It really isn't. So that's a big factor. And it has a lot to do with just not having faith in healthcare, or not wanting to go in a place where you just don't feel like you belong, or you just don't feel comfortable. Does that answer your question?
Yeah, I'm just curious. I know you talked about sort of your research is looking at that community piece, and sort of I'm just curious about how you guys are responding to that.
It's again part of feeling like you're on a different planet. So people like Christian Hospital is, on the north side of Highway 70, and it's some people like it, some like Barnes-Jewish. Barnes-Jewish is just huge and kind of overwhelming. And we also found out that I sort of assumed women would get the choice of which hospital they wanted to get their surgery at. Nah, they do it by address. That's not, any social worker would say, probably not a good idea, right? If people don't feel comfortable going into the Central West End, then they probably should, be able to choose going to Christian. So, James.
Sometimes there's also sort of what I call sort of the context and communities of color myths about certain things, and that that sometimes drives decision-making. Have you been able to identify in your work in the African-American community any specific
Well,
that rise to the surface?
The nice thing is, in Chicago and in St. Louis, you hear less often, it's just going to happen, you know, and if you do the surgery, it'll spread. We did 53 focus groups in Chicago, and we found that was pretty much said by 70 and 80-year-old women, and it was heartening to me that 20 and 30-year-old women weren't saying it so much. So it's certainly a part of it. And just, you know, the whole idea of the Josephine Lax, and just, that was not that long ago. She's the woman who developed ovarian cancer. Henrietta Lacks, sorry, thank you. Henrietta Lacks developed cancer, didn't get to treat it in time, then ended up, she was near Washington, she was in Baltimore, I believe, ended up going to the National Institutes of Health to be treated. They weren't able to save her, they kept some of her cells. And her cells have been used in medical research for a long time. So people do hear that. They do hear Tuskegee, and there's not trust. And I'm not even sure I completely trust. There was a panel of federally qualified health clinic personnel. Most of them were African American. And the audience was asking questions at an event, and there was an older gentleman from the NAACP. And he got up, he looked like he was 80, and he said, "Why should we trust you? You know, why should we trust you? My people ask about medical experiments and things." And every one of the people on the panel said, "Oh, no, that doesn't happen. We've got these," and I wanted to say, don't say that, that's not even credible. I don't even believe that. You know, say that this is what we do. It's always an issue, and this is what we do to try to avoid it. But to say it'll never happen just seemed to me to strain credibility and not increase trust, but maybe decrease trust. So I think the class helps. People like to be listened to. When we did the support groups in Chicago, we had 53 of them, which was like 500 some people. And the way we advertised was to say, we want to hear your voice, not like you're lucky enough to be in a medical study. You know, we just went to pick up basketball games. I had students all over the place inviting people to be part of the groups, inviting and saying, we need you to do what we're doing better. We need to hear your voices, and that really worked. So the Chicago Defender did an editorial urging the community to be part of this important study, which had really helped. And the University of Chicago they had sort of an adversarial relationship, so they said, "What'd you do?" And I said, "I just talked to people." I mean, yeah.
Excuse me. I got a kind of, I think it's an interesting question. I came here today because I work on a property. I work for a local affordable housing organization. And one of the properties I work on, and I do all the programs and services, is 90% African American, I think 7% Latino, 3% white. And there is an incredible rash of, there's a large amount of women on the property, and I found out that there's a large amount of women with cancer on the property. Different ages, I've never seen it, but I mean, I've never been in this, I guess, position. So, the community is difficult to engage, partially probably because I'm white, which I'm aware of. However, with your presentation, you are talking about a similar community. And my question is more on that kind of that community level of how do all these factors lead to breast cancer in a certain race or group. And so, but you can't, in a certain way, you can't talk about the behavior of it, or you've already focused on behavior issues, but that hasn't helped. And so you can't focus on genetic disposition. You can focus on social circumstances and the shortfalls in medical care. So on the social circumstances is education, the social isolation, crime, neighborhood, all those factors. And so how do I go back into this community when this is pre-cancer, or say they haven't gotten it yet, and almost do a kind of preventative measure? How do I engage community stakeholders or community members? How do I frame the conversation?
Yeah, well, so it seems to me starting out by getting people to agree that there's a disparity and that healthcare isn't the way people want it to be. And I'd work with community partners. I would try to find, there've got to be some people who are concerned about this.
Right. See, what the community you had was already engaged community. You had a breast cancer community. This is...
Actually, I didn't.
But
Oh, I see what you're saying.
you did the neighborhood walks where everyone had breast cancer already? Or they were...
You had identified.
Yeah.
People by breast cancer. So you already had a registered group of engaged
Well,
people.
okay. So let me, sort of. But we also were able to get a groundswell in the community. So there's research and there's movement to change policy.
Right.
So what we did was put these results out and talk to key people, people who were health activists, maybe living in that neighborhood, people at the health department. My colleague at University of Illinois always aimed at health department people, and I always aimed at grassroots. And thank heavens we listened to one another because we needed both.
Yeah.
So it just kind of took on a life of itself. And something called the Metropolitan Chicago Breast Cancer Consortium came together, which was individuals from a lot of socioeconomic statuses, providers, some academics, and health department people. And it, over the years, got the ears of people. And we passed the Illinois Breast Cancer Disparities Act in 2009 based on that. I did nothing. I mean, all I did was do the data. And it made those clinics that weren't able to hire anybody else, that just had one mammographer, it let them be reimbursed for women in the breast and cervical cancer program at Medicare rates instead of Medicaid, which were 3 times higher in Illinois. So it incentivized the clinics. I liked it because it was a carrot, not a stick. But I think you just have to talk a lot about it, and there will be people. 1 in 9 women have breast cancer at some time in their life. And the thing is that if you get the early form, that's more lethal and aggressive and more prevalent in women of West African ancestry, it's gonna be a worse course. It's gonna be a more difficult course. So first of all, just talking about that got people interested. But I think you can't just go out and talk to individual people. You've got to find key people. Maybe there are going to be some activists. That's the way it usually starts. And work with them. And telling people that social determinants have something to do with cancer is like, they're not going to be surprised. They're going to say, you just figured this out. So it's got a lot of credibility. And what you do is an issue, because I like activism to change neighborhoods. So what we're trying to do is change some of the laws, receivership laws around these vacant buildings, that the people who own them don't pay taxes on them, they don't board them up, and they change the character of neighborhoods. That's one thing. Finding safe places for women. I found that, like cognitive behavioral, I think is almost cruel. Because if you're trying to get a woman to cope better, who's like so far exceeded any human being's ability to cope, that's asking too much. Or, we also talked about relaxation, but if you're in a place that's really dangerous, relaxing for like the full 1 hour, probably not a good thing. So, bringing together, trying to take back neighborhoods, trying to find safe places, trying to build some political constituents to help neighborhood clinics, and just give a better picture. People feel empowered when they know it's not their fault they have cancer, you know? I mean, getting past that. So I wish I had better answers.
That's okay. No, thank you.
I think we're calling.
Okay. Thank you all.